So if we can start, that would be great. Just to say that this is being live streamed, and there are lots and lots of people who obviously weren't able to come to the physical exhibition. So we'll make sure the link is tweeted sort of now, but I guess people who've been here since this morning will know what that is. Well, it is my real privilege to be the chair of this incredibly great panel, considering the sort of the implications of transparency, open data in relation to health in particular. I have the enormous privilege of being the National Director for Patients and Information in NHS England, which gives me responsibility for open data and transparency across health and care. And I just thought I'd quickly tell you how I came to this. I came to this because I used to be a journalist a decade or so ago, and I got a phone call one day from my mother, who was a GP in the southwest, and she was in floods of tears, and she called me because she feared that one of her local consultants was actively killing his patients. And this is in Exeter, and my mother was late 50s. She had never even thought about being a whistleblower of any sort in her life. And I was very worried for her. I was actually the news editor at the Sunday Times, and I knew what happened to whistleblowers. Whistleblowers, for whatever the best of motives, are not rewarded for their courage in most cases. So I was really torn as to what I should advise my mother to do. Should she go public with this concern or not? In the end, at any rate, she did go public. She became a whistleblower. And the subsequent inquiry into this chap disclosed that he had caused the death, the early death of at least 11 women and probably 50. He was a consultant radiologist in the hospital we have in Exeter, and he was an alcoholic, and he had been stuffing mammograms from referring GPs down the back of his radiator and ignoring the referrals. And the scandal for me was both just the sheer tragedy of that happening in a modern health service, but the biggest scandal for me was the fact that the hospital could have stopped that very much earlier if it had just used the data, if it had just made transparent the data on the performance of this individual much sooner. So for me, transparency is not just about accountability. It's about actually how human do we want our public services to be. It's about their humanity. We're going to hear from some extremely distinguished people today on how transparency can do things like reduce mortality outcomes in hospitals. We're going to hear about how it can transform the relationship between people, a public service, put people in control, give patients real, meaningful control of their health. But at its heart, for me, transparency is about how human do we actually want to be, how respectful and dignified do we want to be, particularly in healthcare, in relation to treating and respecting our patients. Now, I actually believe that 10 years ago, this was an impossible conversation. 10 years ago, I set up a business. After I'd had this conversation, it led to various things. And I remember being at a meeting of some very leading clinicians where I and other colleagues who set this up were accused of being members of Al-Qaeda because of even the concept of transparency, reporting outcomes on doctors was considered such anathema, so threatening that we were considered terrorists. And I think the last decade, thanks to the leadership of many of the people speaking today, has seen an incredible shift in attitude. I think clinicians in England now are the majority certainly are completely committed to the idea of openness, of sharing their data, of striving for constant improvement in the quality of their practice. And I think there are things we can share with other countries, other open government partnership countries, about some of the things we've learned, some of the challenges we've faced in moving over the last 10 years from a place of darkness, in my view, to a place of real openness. And today in the National Action Plan, in the Open Government Partnership programme, we announced a number of initiatives which just, in my view, go to confirm, underline the commitment that in England we have made towards transparency in healthcare. So with those words, and just to say thank you for those who are physically in the room for attending the session, thank you to those on the live stream for dialing in. I think we are at a turning point. I think transparency, open data and health will be the most important public policy contribution that our generation makes. So big words, but very, very meaningful, I think. So I'm going to hand over to Bruce Keogh, who's going to give us our keynote speech. Sir Bruce is an old friend of mine. Sir Bruce has been one of the most ardent advocates of transparency in healthcare, and he himself has been a change agent on a truly global scale, having basically led one very important part of this revolution, which was to encourage individual clinicians to be open about their own performance. So, Sir Bruce, please.
Tim, thanks very much for that kind introduction. So my name is Bruce Keogh. I'm the National Medical Director. And I have a pretty simple philosophy, and that is that anybody who aspires to be professional should be able to describe what they do and define how well they do it. And if they can't do that, they forfeit a level of professionalism. That applies to doctors, teachers, politicians, all groups of professional people, but it also applies to organizations. So if you take that as a starting point, transparency is no longer just a philosophical or ideological gimmick. It's an essential part of progressing the way that we deliver healthcare services, not just in this country, but in my view, around the world. So in my mind, the future of healthcare is going to be driven by three things, really. The first and number one is economics. The second is a set of public, professional, and political expectations. And the third is the advance of science and technology, and in particular, the advance of information technology, particularly in a world where people all have smartphones. Some more fortunate people have iPads, but in any event, people can connect themselves to the internet. They run their financial lives, they run their social lives, they run their travel, all through the internet. And yet, I find myself asking, why don't we run our own healthcare online or through more smart methods than we currently do? So the internet has done a lot of things. Apart from providing that facility, it's opened up a lot of previously privileged knowledge that was previously held by healthcare professionals to members of the public, to the citizens of every country of this world. And the end result of that is that it has changed and will continue to change the behavioral and social dimensions of clinical and medical practice in a way that cannot and should not ever go back. But it also offers, in my view, significant opportunity. It offers new opportunities for us to analyze, process, and present information that has utility to the citizens of every country in a way that hasn't existed in the past. So people have become their own bankers, their own travel agents, etc., but they haven't become their own healthcare experts yet. But the technology is here. I believe that it's just around the corner. I think that we, as leaders, have a duty to promote and to lead the open data revolution in healthcare. 12 years ago, I sat as an observer in Parliament when the then Secretary of State was presenting the findings of the Bristol Royal Infirmary inquiry, which was an inquiry into unnecessary excess deaths of children undergoing heart surgery in Bristol. And there were several recommendations in that inquiry, but two of them spoke very specifically towards the availability and publication of data. And the end result of that was that we embarked on a very difficult journey for the publication of the results of heart surgery by individual heart surgeons, and I'm a heart surgeon by background. That whole debate was contaminated by a feeling of utter fear among the surgeons, by fear over methodology, fear over presentation, fear over how the public would handle the data. And we got through all of those. But it was a very difficult time. We got there. But what that did was, it not only brought a level of individual professional scrutiny and organizational scrutiny to the results of surgeons so that processes were improved in hospitals, but it also resulted in a significant reduction in mortality for heart surgery in this country, to the extent that we are now statistically better than average than the European average, with results that are twice as good as Germany and several times better than some other countries. So it's done enormous good to heart surgery in this country. Now, that powerful combination of professional and public scrutiny, I think, we need to bring to other areas of healthcare. We have this year brought it to 10 other surgical specialties, and it is our intention in NHS England to extend that into other more complicated areas of healthcare, so I invite you to watch that space. But you know, there's more to transparency than just publishing results of individual surgeons or clinicians. Some years ago, Tim Kelsey and I were asked with others to set up a new website to publish the performance of hospitals in this country, and that was called NHS Choices. But it soon became clear that people wanted more than just the ability to look at results. They wanted to be able to choose their treatments, to understand treatment options, to understand the pros and cons of those options, and then once they had made a decision on that, to look at where the best place was to have them done. And that website, NHS Choices, now, I think largely down to the vision of Tim Kelsey, has 1 million visitors a day. That is an extraordinary achievement, I think. And it is one of the places that we publish as openly as we possibly can much of the data that's available on healthcare in this country. And it is important because our NHS is a tax-funded system. It is owned by the people. It belongs to the people. The people are the shareholders, and sadly they are occasionally the reluctant customers of the service that they partly own. And one of the things that we've given some thought to is how we start to present that information. And it strikes us that there are 5 things that any healthcare system should do. The first is that it should prevent you from dying prematurely where it can. The second is it should look after you well if you have a long-term condition. The third is that it should look after you well if you have need a short episode of care, such as cataract operation or a broken leg. The fourth thing it should do is it should treat you well. And what I mean by that is we need to significantly improve the level of customer service that we offer. And fifthly, it should offer you safe care. And by safe care, I mean that most patients will accept that their disease has a risk. They accept that the treatment has a risk. What they should never have to accept is that the way that we organize and deliver our services influences that risk in an adverse way. So within those 5 domains, we have developed a number of different measures. So in terms of preventable mortality, we publish unit data on hospital mortality. We publish that on choices. We publish it in many areas down to a specialty level. In terms of looking after people with long-term conditions on NHS Choices, we have some measures of clinical outcomes, but we combine that with a sort of TripAdvisor type facility where people can comment on the treatment that they've had and where they've had it. And that requires, of course, careful moderation. We have information on outcomes and processes of each and every general practice in this country. With respect to acute episodes of care, which are largely delivered in our hospitals, we have surgeon-level data on 10 specialties that I've alluded to. We have more generic data on different specialties in every hospital. And more recently, and you'll hear this from Dan Wellings later, we have introduced something called the Friends and Family Test, where people are invited to advise us whether they would recommend the organization that they've been treated to their friends or family. We use that also for measuring the level of customer satisfaction with our services, and of course the TripAdvisor facility helps to supplement that. We also publish information on complaints and serious untoward incidents at a safety level. So I think we've made quite a lot of progress in terms of publishing data in this country, but we have a long way to go. You will hear during the course of today about a proposal to initiate something called care.data, which is where we will be bringing together patient-level data from primary care, secondary care, and mental health in an anonymized way and putting that out into the public domain to allow other people to analyze how we deliver our services and help us improve them. But we can go much further still. People will have some difficulty with the open data in the same way in my specialty that years ago people thought that heart transplantation should be illegal, that it was immoral, that it was against God's will, and all sorts of things, and now it is simply a routine procedure. And similarly, we will go through the same sorts of discussions with open data where people feel the difficulty and retrospectively look back and see the inevitability, the advantages, and the utility of going down that journey. We will, in time, need to move away from some of the very easily measurable data on individuals, such as height, weight, that sort of stuff. And we have to accept the inevitable advancement of science, where we shift from that sort of data, which is called phenotypic data, and start to link it into the genotypes of individuals. And that will open up a whole new debate about the application of genomics to risk stratifying patients and populations so that we can devise our services and offer the best results accordingly. Because we do know that if we understand that kind of data, we can bring much more targeted and effective treatment with much better survival rates to patients with cancer and some other conditions. So we're at a point in my mind where broadcasting was with the advent of the shortwave radio. We're at an inflection point in the curve where we're going to see an exponential growth in the way that people analyze, present, and approach open data, if I can put it that way. So I see a future for our NHS and for many other healthcare systems, which is underpinned by the availability of open data at a number of different levels. I see a future where that data is processed by a multiplicity of people with an interest in that data to help the delivery of services. I see a future where health services turn from simply being a delivery industry into a knowledge transfer industry, primarily, which is supported by healthcare delivery. And I see a future where people can understand, because we give them the data that they need, the pros and cons of the treatments that they're being offered by our healthcare system. And I see a future where patients own their own medical records and grant access to others to view them. And I see a future where patients can book appointments and book to see who they want to see online. Importantly, I also see a future of digital consultations where the experts come in to the living rooms of those people that they can help and seek their help. I think that will break down barriers, it'll break down geographical barriers, and it'll break down barriers of time. It'll bring an immediacy of access to healthcare 24 hours a day that we can only dream of now. So I think we are at a very important point in healthcare. I think how we proceed will be determined by the limits of our imagination, not by the limits of technology. And just to give you an example of that, I'd like you just to imagine that you were on Christopher Columbus's ship and you've just arrived on the eastern seaboard of the United States in 1492. You're really pleased to be off the ship, you're having a few drinks, and somebody says, you know, that was an awful trip, you know, but one day these ships, they're going to fly through the air and we're just going to take a day. And what would people have thought? Complete madness. What we think is complete madness now is getting on a sailing boat and going across the Atlantic. I know Tim Kelsey's done it, but not many people do. So I would put it to you that the impact of open data will be felt much sooner than many people think, and that will bring a degree of discomfiture to those of us who are in positions where we can influence the way our healthcare system works. But that discomfiture must be welcomed, it must be appreciated, because it's going to help us shape the future for those generations who are going to depend on us. Thank you very much, Tim.
So we move on now to Dr Dan Poulter, who is the Parliamentary Under Secretary of State at the Department of Health and also MP for Central Suffolk and North Ipswich, but of course himself a doctor. Dan, please.
Thank you very much, and good morning, everyone. I have, unfortunately, to dash over for a vote at the House of Commons a little bit later on. So for me, the main focus, I think, is helping to stimulate some discussion and talk about the big challenges that are facing not just the UK, but also every country that every country in the world, which is that we all have, thanks to the advances of medicine, a lot of people who are living a lot longer. Those people living longer with multiple medical conditions, with diabetes, with heart disease, with dementia. And there's a very big human and financial challenge in making sure that we provide dignity in the care of those people and make sure that we inform the care and that care that's delivered in a very personalised way. Now, we know, as you heard earlier, that we have to make sure that even in a publicly funded health service like the UK, and we're very proud that we have a publicly funded health service, very proud of the NHS to have worked in it and now to have a role in setting the direction of travel for the NHS. We have to make sure that the money that goes into the NHS is always spent on patients, and as much of the money as possible is focused on the front line, and improving data transparency and openness is key to delivering that. It's also key, as you've heard, to improving patient care, to making sure that we deliver care in the best way for patients, helping people and their carers to make more informed choices about healthcare, making sure that we keep people well and supported in their own homes and in their own communities. That is where transparency, openness and improving the way that we deliver care, better using technology, has a key role. But that challenge that we face here is faced across the whole world, that even though we are putting more money into our NHS, in real terms, small real terms growth in the budget, that we have to make sure that we address the human and financial challenge of looking after many people who are living a lot longer, and also looking after those people with long-term conditions and disabilities. And the imperative was highlighted by the Chief Executive of NHS England, as he is now, David Nicholson, in 2009, when he said that every year that we have to make efficiency savings in the system to make sure we can put that money back into frontline care. And there are a few areas where we're doing that, and through transparency and openness in government and transparency and openness in the NHS, we are making sure that we do that. First of those is having more transparency and openness and recognising that there had to be a period in this country of wage restraint in the NHS. But more importantly, we've also focused more recently on making sure that more money is directed to the front line, and the importance of having better procurement practices throughout our health service to deliver better services, but also delivering and freeing up more money for frontline patient care. So earlier this summer we published a roadmap to better procurement, and transparency was the key to that, making sure that each and every hospital publishes what they pay in future for the goods and services that they procure, making sure that there's transparency in the amount of money that's spent, for example, on temporary staffing. And we know that temporary staffing is something that's undesirable both financially, but also it reduces the continuity of care and the quality of care sometimes that's available to patients. So having transparency in the way that hospitals do business, transparency in their accounts, is a key driver and a key way of making sure that the money that we put into our health service, money that should be spent on patients, is always prioritised for patients, and that where there is waste in the back office, in the way that hospitals buy their common goods and services, that can be eradicated, and in future we can have a more efficient health service that has more money to do the job that we all want it to do. But also the other part about transparency and openness, and you've heard a lot about the patient-centred approach, the friends and family test that we've introduced to make sure that routinely people are asked when they turn up at a hospital or at a care setting, that people are going to be asked the question, whether they would recommend the care they receive to their friends and family. And if we want to have a patient-centred approach to our NHS that values what patients think about the quality of care that's provided, then that friends and family test is very important. And it's not just about collecting that data, it's about publishing it openly and transparently so that it's there for the public to see and for clinicians as well to act upon where appropriate to improve the care that is delivered to patients. But also key to delivering and transforming the way we deliver services, which is the key challenge about looking after people with long-term conditions with greater dignity in their communities, is about making sure we have a more integrated model of care. And information technology, making sure that GP surgeries can talk better to pharmacies so that people can collect their prescriptions more easily, making sure that social care that's delivered by local authorities and the NHS can talk better together, that hospitals can talk better to the GP surgeries and pass information about patients much more freely. Those are the sort of things that we are now beginning to grip in a much more meaningful way, and those are the sort of things that will help transform care into a much more seamless system of care that makes sure that individuals' care needs are properly prioritised. So as you heard earlier from Sir Bruce Keogh, there's a lot that we have done about supporting greater transparency in the clinical setting, publishing and focusing much more on the outcomes that individual surgeons have, individual hospitals have, with the quality of care that they've provided. But there's also a lot more that we need to continue to do to make sure that we use technology to drive better joined-up care for people when they move around the health system, to make sure that we support people and families and their carers to look after themselves in their own homes and make sure that we provide that dignity that we all know is so important in the care of older people and long-term conditions. So I think in the UK we've come a long way on transparency. We're doing a lot to make sure that money is better spent, making sure that hospitals are held much more accountable for how they spend public money, and to make sure that that money is not wasted and is spent on patients rather than on competing initiatives. And we're also making sure that much more transparency is there so that patients can genuinely feedback what their experience is of the NHS. And I'm sure if we carry on with this journey, then we'll be in a much better place as a health and care service in the years ahead. Thank you very much.
Thank you very much. Sir Nigel Shadbolt, I guess everybody in the room will already know Sir Nigel Shadbolt. Sir Nigel is in fact our first knight of open data, having been invested yesterday with the knighthood, very well deserved for his championship of the open data movement for so long. Sir Nigel has also been very intimately involved in healthcare. He's been on the transparency panel in healthcare for some time, and of course currently is the chairman and co-founder of the Open Data Institute. So,
Thank
Nigel.
You, Tim. Thank you. Okay, well, a little bit of inspiration, I guess. There's my Twitter handle, @Nigel_Shadbolt. I always like to get a few more followers. Shouldn't miss an opportunity. Florence Nightingale. She submitted, a great open data advocate, actually. When she submitted her parliamentary report on deaths in the Crimean War, she not only did a huge job in changing the perceptions of where mortality was actually arising, which wasn't largely on the battlefield, it was in the dreadful insanitary conditions following wounds, or indeed just generally in field armies then. But she provided us with great infographics, so her Coxcomb models, which actually showed very visibly and easily, parliamentarians just got it. They just saw this astounding kind of revelation as to where the actual problem was. Bit of a heroine, I should say, of mine. But, we've been doing it here, as Sir Bruce has been pointing out, and with support from really committed government ministers. Actually, under two governments. This government really has accelerated the focus, though. But we began to see the effect when we were starting to publish out our hospital infection data. We did have a problem in our hospitals with MRSA, C. difficile. We were killing patients in our hospitals with infections. That data, when it's published out as league tables, allowed people to see why was there so much variation in best practice or poor practice. And those at the bottom of the table, pretty well you can expect, wanted to find out, get on the phone to those who were doing better and find out why they were doing better. And this was not rocket science. This was really basic sanitary procedures in many cases, deep cleaning, a range of activities that have led to an 85% decrease in infections in our hospitals since that data has been being published. We've got the example of prescription analytics, which I'm very proud of. This is work where we've been looking with the Open Data Institute. One of our startup companies has been looking at the open data that GPs now in England write out every month, all prescriptions as open data. Not to who, but what the drug was. Now that, analysed over a year, has given us an insight that one class of drugs, statins, had we been prescribing the generic version, we'd have saved over £200 million to the NHS in that year. And people will say, but there are good reasons why proprietary drugs are... yes, there are good reasons. Sometimes incentives aren't appropriately aligned, sometimes just not an awareness of other people's prescribing behaviour. The challenge with this data is to understand how you modify behaviour. That is the challenge in all of this. The data, as Sir Bruce was saying, in itself is just the precondition to getting things changed. We've got other good examples, shocking examples. Actually, this is where actually organisations who aren't in some sense the primary health deliverers. This Lambeth, one of our London councils, publishes as open data childhood obesity statistics, along with a lot of other data. It just shows you when you look at those shocking graphs and maps that we have this incipient, huge problem in the UK of probably diabetes at very large scale, when we have our 14 and 8-year-olds suffering at the level they do from obesity. We have, as Sir Bruce again is saying, outcome data around a whole range of clinical outcomes and surgical outcomes. And there's more. This is one of my favourite sites, actually. Again, getting the information out there in a very accessible way is another precondition for getting people to think about where there are variations. This is the Longer Lives work from Public Health England, which was using a range of data to just compare different authorities in terms of basic mortality rates. And the fact is, in the UK, and people say this is no surprise either, but actually it's still a shocking fact, that in one local authority, you are 2.5 times more likely to die prematurely under 75 than you are in another. Okay, just that's a big variation. And even within matched socio-demographically equivalent local authorities, so the ones who are really quite affluent, you can be doing quite badly compared to your peer group. That stimulates a debate, a very serious debate, which gets people thinking and challenging the issues of the time. So at the Open Data Institute, one of the things we have been doing, and we are very keen to work with health, as one of our beacon examples of where we can get data that can make a difference fast, how we can present it, how we can analyse it, how we can get deeper under the skin. And I think what I want to spend a little bit of time doing is actually talking about some of the things we need to understand. Open data in itself is just one of the elements we have in our open manifesto, from licenses to standards to source to participation. Those classes of open give you this remarkable phenomenon that I think of as open innovation. If we need anything at all in our health systems, it's to unlock the innovative capability of our people. And not just medical professionals, but more medical professionals, of course, but a whole range of other people who will bring their expertise to the table. And it isn't then all about data. It's hugely about licensing. It's about these bizarre purpose-limited restrictions you sometimes get when you get a data set that says you can do everything with this except bring this country or this public sector service into disrepute. You can do anything with it you like, but you can't do this or that with it. We've got to try and remove those barriers. We've got to try and get open standards which, if they're not there, you find yourself locked into some IT provider's proprietary formats, which are great for them, perpetual lock-in, and terrible for the actual general ability to get things done more widely. And we're making real progress there. Liam Maxwell and people in the GDS and others talking about open procurement and indeed in the health service, but open procurement models. Let me just end on what I think, this is a poster child for open innovation, by the way. If you don't know, this is Jack Andraco, an American 15-year-old who came up with a 10-cent paper-based sensor for varieties of cancer based on his own efforts to plough through and openly innovate across medical literature, across proteomics, across where he could look at what was an $800 a shot and worse sensor solution that the medical industry provided to something. He just disrupted assumptions. His biggest complaint was that he couldn't get at the medical literature because it was very expensive to buy access to the medical journals. So again, open access to appropriate peer-reviewed scientific literature, hugely important in this area. Last few minutes on the challenges. I think it's really important, whilst we're trying to cheer people along, that we understand that there are still huge challenges in just getting health delivery and social care delivery aligned appropriately with incentives to even produce high-quality data. Whilst we're producing it, you also talk to people who in the back of the corner will say to you, the real problem is there's no audit trail between actually what's reported and what actually happened in the theatre. Not necessarily, not provably so. There are air gaps where some kind of degree of transmission of the facts to what's reported is happening. We have to work on improving the quality of data. We know that data often is seen as an encumbrance, as a piece of bureaucratic overhead. Why should we care about it? we have to change the regime so that people are actually rewarded for the production of high-quality data. It's part of them being competently and appropriately advanced professionals. We do talk to ourselves sometimes. Actually, in flexible legislation, I should just say, some things in this area drive you to distraction. The fact we can't actually publish our death certificates openly in England is just an extraordinary piece of nonsense, and it will take some serious re-legislation to get beyond that, but we must kind of keep on hammering away at this. Every jurisdiction is different. We kind of like to think the UK is doing well in some of these league tables, but there are these local idiocies, and everybody has their local idiocies when it comes to difficulty in releasing health data or any kind of data. And an idiotic assumption around who can and can't see data is really, really helpful for getting people worked up and getting a sense of mission going. I think there's a challenge around consistent policy across governments, that departments still have a natural tendency to silo things away. We don't communicate our successes maybe as effectively as we should. I mean, there are a lot of them, and we see increasing numbers of them, and we should really start to think about how we more effectively mobilize those stories together. In the way Sir Bruce was saying, there is really an opportunity. This is a very disruptive opportunity to make health delivery look very different. I think it's going to also change because the new class of devices that we now have to not just measure our illness, but our well-being, means that we don't even necessarily have to start at primary care. That one of the things we'll start to see is through all sorts of devices, we know more and more about an individual's lifestyle, and maybe they will begin to provide more and more information into us in that style. We do need to worry, I've talked about proprietary formats, but there's also a challenge around professional bodies who actually, and particularly I would suggest it's no surprise to many of you that medicine has got a lot of professional bodies, and many of them think they are the custodians of true interpretation and insight around that data. And of course, some of them will even flog the data if you're willing to bite off them. Seems to me we have to really talk hard to our professional bodies, our colleges of surgeons and anesthesiology and pathology, and persuade them that there is more in this activity if you produce your data openly. So I'm a little bit worried in all of this that we don't end up in a world in which we have this onion ring of it's open for these people, open for this slightly wider group, open for this slightly wider group. And because for me, the power of open is really open. Recognizing that, of course, with patient data, you have the huge challenge of privacy and recognizing that we need to take care of handling their own personal data effectively. Okay, and a final point, releasing new data sets and acquiring new data. And I'm really pleased to hear that the plans, and NHS is to be commended on this, to keep pushing, to put more out there. The other challenge is to ask yourself, and every modern state in this data-driven, data-dependent world is going to have to think about it, what data aren't we collecting that we have to? The fashionable thing to do is to say we must be collecting a lot of stuff we don't need. There's probably a lot of stuff we should absolutely be collecting that we don't. And given an opportunity, again, in a sensor-rich world, to pull data in relatively cheaply and publish it out at marginal cost, that's something we must address.
Brilliant.
Okay, thank you.
So now we're just moving on now to just a couple of sort of views from, as it were, the NHS perspective, the UK perspective. One from a great member of my own team who's going to talk about customer insight and feedback data, which I think we're doing some very important work in terms of transparency. And then from Mike Hobday, who is the Director of Policy and Research at MacMillan Cancer Support. And perhaps I could ask both gentlemen if we could keep it relatively short, just so we get to the panel at the end and we have adequate time to debate. Great. Dan.
Okay. So, good morning, everyone. So the key title to this is listening. It's the word listening there, and it's thinking what we're getting in from the data. So just to tell a brief story, before I joined NHS England, I worked for a company called Ipsos Mori, which was collecting data on behalf of the NHS. And what's extremely interesting for me is that we would deliver reports to the NHS and we would have no idea what happened next. And now I have some idea. And there's a lot of work to do. And it's a lot pretty.
Yeah, God. Keep quiet.
And we need to think that. There is so much data that we're collecting. The key question is, what are we doing it? How are we listening? How are we making it work? And the story to tell you was we did some work around mixed-sex accommodation. And we interviewed someone who had gone into a coma, had ended up in intensive care, had realised that she was not in the clothes that she was in when she went in. And no one explained to her how this had happened. She didn't want to ask for fear of the answer. She didn't sleep for 4 days and 4 nights in intensive care. And I told this story to an audience of doctors. So apologies to doctors in the room, but the first response was, does it matter if she was better? So that's the question. That's the question that we ask, and that's why we collect the data. Okay, so what's really interesting for me is this word insight. Now, insight is much contended, and I think it's very interesting when you think about the private sector and what they do with insight. Insight is not just collecting data. Insight is so what? What do you do with it? It's about learning what you can do with a data set rather than asking what you can't do with a data set. And this is really an important thing. Every data set will have limitations, as all of us in this room know. But what can you do with it? What does it tell you about that? And I think that's the gap. There's a cultural gap between understanding what are we learning, what can we take away from that data set, how can we make a difference from that story, what do we do differently? And that for me is absolutely key on this. It's very interesting for me, having worked in the private sector many years ago, that the robustness and the rigour of the data collected in the private sector is in no way as strong as the data we collect. But they use it far more. They learn to listen, they learn to understand, they have everyone involved. And I think this is absolutely key in terms of, so I'm going to rush through a little bit in terms of time, but the key thing on this slide is knowledge for all. So Google have a very interesting saying. If you have a director of innovation, you're in trouble. Anyone here, I'm sorry, but if you have a director of patient experience, not to put them out of business, I apologise to anyone who is a director of patient experience, but it's everyone's business. It's everyone's business. In the private sector, it's not just one person, it's the market research function, it's everyone. Understands the data, understands the customer, understands the user, understands the patient, and listens, and then acts. And that, for me, is absolutely fundamental. And an interesting lesson for me on the inside now is that we collect more data than we know what to do with, and we need to learn to know how we use it. And that, for me, is absolutely fundamental. Okay, so the Friends and Family Test is the cornerstone of much of what we're doing. Now, to introduce this is a census approach to asking what's happening out there. It's not a randomly controlled trial. It's not a quota sample. It's a census approach. It's as much about everyone having the opportunity to fill it in as what we then do. And the key question which we're asking people to ask is why? Why is this happening? Why are we getting the scores? And the other thing to focus on, I think it's very easy in the NHS to focus on when things aren't going well. But one of the other interesting things is that we're hearing that you can use this data to show people where things are happening that are going well, where staff are getting feedback, direct feedback from patients. And it's as much about the model of using data. So there are 2 reasons why we might not be doing the right thing. One is we're collecting the wrong data. One is that we're disseminating it in a way that people don't understand. So there is the inpatient survey which we conduct in the NHS as well. It is a randomly controlled sample. It's statistically rigorous, it's robust. The data we get from it is disseminated 6 months after we collect it. This is around real-time data, what happened last week. In that meeting on a Monday where you sit down with your staff and say, what did we do well last week, what do we need to improve upon, that's where you need to be using this data set. So it's about what you use a data set for, what you take from it, you understand its limitations, and then you take something from it. And that's fundamental for me. Okay. So this is the thing about the Friends and Family Test. Certainly people have opinions on, and I think that's right. And it's very interesting to have this debate. And it's around the usability. For me, there's something around having a data set that is set up in a local way that people know they can use. There's lots of data that shows national surveys, when they land on someone's desk, people think that's not my patient group, that's not where we are. So there's this question of ownership. So we've set it up in a way that's permissive, that people at their local area, they own the data. It's not us at the centre saying, you're not doing this or you should be doing this. It's them owning that data. And that's the balance between the usability and the robustness. And the census approach for me is absolutely key. So we're still getting to a stage with inpatient survey now where we're getting 1 in 3 patients are completing this. Now, the GPPS survey, which is a general practitioner patient survey, is around 35. So let's again think, let's look at the limitations of the data set, but let's be clear, what can we take away from it? What do we learn? And use the other data sets. In the private sector, no one thinks we do 1 survey a year, which tells us everything we need to know about our customers. And I think that's a mindset that we need to move away from. Okay. So, as of yesterday, nearly 1 million responses since April 2013. I'm hoping this morning there may have been 10,000, which pushes us over 1 million. And that's something, isn't it? You know, and there will be critics, and there are people that say what we can't get from it. But for me, that's not bad. The next step for us is to ensure people are using this data in a meaningful way that makes a difference. And that's around culture change. That's around understanding what you can and can't do. Not bad, I think. Good. Thank you very much.
Brilliant. Dan, thank you very much.
Thank you very much. My name is Mike Hobday from MacMillan Cancer Support, a UK cancer care charity that many people will know as an organisation that raises money, funds nurses within the NHS. But MacMillan is about much more than that. We are about evidence-based improvement in cancer care, in cancer across the UK. We are, we believe, an entrepreneurial NGO, using open data from the government, from the NHS, using big analysis of that data and clinical insight to produce compelling lessons for change about how we can deliver cancer care better. And this is really important because the number of people with cancer, with other long-term conditions, is growing year by year as society gets older. Across the UK, we believe that the number of people living with cancer is going to double to 4 million by the year 2030. Those people will be living longer, which is great, but they will be living with the effects of cancer and its treatment and with comorbidities. We know that the health system cannot cope with increasing numbers of people living with more morbidities without serious reform. So that's why MacMillan believes in evidence-based change. And this is what we want to achieve. 9 clear outcomes that we want everybody with cancer to be able to say by the year 2030. Now, if we are going to deliver the sort of reform, and if we are going to support the health service to deliver the sort of reform that is needed, we need to understand what happens to patients, where it happens, and how to identify the lessons from that. We need to understand what sort of reform drives value. And MacMillan's Cancer Population Evidence Programme, a research programme, is designed to answer these questions, to help us advise the health service how to provide better care and critically how to achieve better value in these very difficult times. So how we do this effectively is about combining information from multiple data sources about individuals' interactions with the health system, linking that data, pseudonymizing it for analysis. So a link, for example, between cancer registry data, every person who has been diagnosed with cancer in the UK, data about their interactions with the NHS and the hospital service, linking that with data about the costings of individual treatments within the NHS, helps us to create a clear understanding of the cost of the cancer journey, both on an individual level and thereby on a population level. Now, if we analyse that with clinical input, we can get real important and meaningful insights for the health service. So as an example of that, MacMillan supported an evaluation of a specialist community palliative care service in Midhurst in the south of England. And what we showed was a gold standard service based on early referral of patients to specialist palliative care, based on community-based support, active clinical intervention in the patient's home, so an expensive service. Firstly, delivered really high-quality choice in terms of the percentage of people, 75-80% able to die in the place of their choice. But because they were well supported at home, spent less time as inpatients in hospital, and the expensive service on top of what happens in the NHS gives a 20% saving for better quality. And so MacMillan can take this model, and what we're doing at the moment is seeking to roll that out to half a dozen palliative care services around the UK so that they can build on and learn the lessons from this, and we can show whether this really is a new model of end-of-life care. And this is the sort of insight about quality, about value, that comes directly from the ability to analyse data within the NHS. A second example, cancer increasingly as a long-term condition. Again, the ability to link data together, to identify pathways that individual patients go through after their diagnosis through MacMillan's Roots from Diagnosis programme. Again, the analysis of pseudonymised linked data sets means that we're able to create or to demonstrate outcome pathways, showing the variation in the different pathways that patients go through after their treatment, and how much those different pathways cost the health service in terms of the delivery they have. So we can show which are the cancer patients who are really expensive. And it's not the very ill, and it's not those who live a long time. It's the people in the middle, of whom there are many and are going to be more. And what that means is that understanding the cost of the patient journey, we can start to look at how we create stratified tariffs for supporting people in the period post-cancer treatment. And at a local level, we can look at the different outcome pathways that that cancer patients travel along. And this is work we're doing in partnership with the NHS in Sheffield. Is saying if these are the outcome pathways that cancer patients go along, and this is how much those pathways cost, then what are the interventions that can put individual cohorts of patients onto higher value pathways where they get better outcomes for less money for the NHS, moving away from a one-size-fits-all model of cancer follow-up into an evidence-based process to deliver better value for patients. Very quickly, we're really proud to work in partnership with Sir Bruce's team and Tim's team on the Cancer Patient Experience Survey. Again, the NHS England producing very high-quality granular data, cancer team by cancer team across England, now happening in Wales, looking at how the teams rate element by element of cancer care for their patients. And it's the use of this open data by MacMillan as a charity that wants to engage in this space, working with providers, showing them through top tips and so forth, how they can improve the quality of their patient experience. So we're glad to see that time by time, Cancer Patient Experience Survey results improve, showing commissioners what's happening in their localities, so they know what they're paying for and where it works well. And through tools like this, the Choosing Your Care and Treatment tool that MacMillan has produced and that we're now developing with the National Cancer Peer Review team, allowing cancer patients at the point of diagnosis to say, what is my experience going to be like if I choose different hospitals? Not only as a choice tool for people with cancer, but as a demonstrable demonstration to hospitals and clinicians that they are being rated day by day against their neighbours, and providing an additional personal incentive to professionals who want to improve what they do year by year. So I think this is a really exciting agenda that we're all moving into. Health data has been treated almost as a byproduct of the purchaser-provider split, but there is increasing opportunity to use this open data to drive real change and real improvement in outcomes for patients within the NHS. So the announcements today on care.data, the whole journey of what the government and the NHS is doing, is really critical in tackling the challenges that the health service says. In a note of optimism, it's important, as Sir Nigel did, to flag up that there are challenges as part of this process. There are different interpretations of data governance. There's limited capability in parts of the system to use the data in the way that Dan was calling on us to be able to do. Ming Tang, the NHS's Director of Data and Information Systems, described the current system as walking through treacle. And I think what's really exciting about this is the way that it's changing. There is, if I say this in an entirely positive way, a brave new world that we're moving into together, ripe with possibilities. And let's not wait for governments and the NHS to answer all these questions for us. MacMillan, as a charity, wants to step up to the plate to help find the answers. And I hope that everybody in this room, in their own way, in their own country, will take some inspiration from the sort of things that are possible, so that we can all move forward and learn together. Thank you.
Thanks, Mike. And can I just say that I think the work that you've done is fantastic, and absolutely this is not about governments doing open data to people. This is absolutely about the kinds of tools you're developing with open data. This should be a moment of extreme creative collaboration. It's really wonderful. So thank you. Right, now we move on to our colleagues from around the world, just to give a sense of where they're getting to on health and open data. So I'm going to start with Romain, who is a colleague from France, head of innovation with the French government in open data. Yeah.
So we are very much in trouble indeed. As Sir Bruce Keogh actually described this vision of an inspiring journey across the Atlantic, I wanted to focus on the first question, which is how do we build the boats to cross the ocean? And I would like to thank, of course, the British government for inviting a observer delegation of the French government and civil society, and NHS for asking our contribution. Today I'd like to describe how we've approached health data and open data in the health sector in France. We have all the building blocks to build those boats, right? We're very lucky that France has been endowed with a very strong public healthcare system that's actually both public and private in nature, but has a single payer model that provides social security to most of the population. So we have a tremendous opportunity to use data on most of the French population to better serve French patients and improve the quality of our care. The second building block is we have a strong culture, maybe not of data, but of transparency and privacy, and so reflections around data. The French Revolution, right, if we go back to 1789, before 1492, was actually built on those joint principles, first of all, of this right of man and the citizen that government transparency is, and also a few inalienable rights which have come to encompass this notion of, the very, very strong notion of privacy. And I guess we also have been paving the way in terms of data-driven innovation, both from the government's standpoint, building an open data policy with the task force EtaLab that I'm representing, data.gouv.fr. There's a very strong innovation ecosystem of startups and corporations and researchers. So all the building blocks are there. We are facing extremely strong challenges as many of us throughout the world, but specifically, and that's one aspect that Sir Nigel Shadbolt was referring to, on personal information and privacy. And as we try to balance this very strong notion that we need to protect patients, hence the data that could be used to improve the quality of care has to be handled with very, very strong and very good stewardship, but also the question of how do we make our healthcare system more transparent. Our traditional approach has not led to sufficient outcomes. We've released data sets on hospitals, how they work, how they function, but not yet data sets that would really enable us to get started on this journey across the ocean. And so the method we're building now is to try to create consensus, to build consensus among the entire community related to healthcare, so practitioners, civil society stakeholders, citizens, of course, but also public health researchers, economists, innovators. And the way we are trying to build this consensus on exactly which data sets should be released is through the launch of what's pretty much, at least in France, a first in terms of public policy delivery, which is an open health data debate, and that's encompassing all stakeholders as well as input from civil society and the general public, leading to a very specific recommendation of which data sets should be made open. And so the Prime Minister announced the principle of this debate as well in health as well as in other important public policy fields. The Health Minister just announced how it would be put together in the next few months. And we hope that this debate will help us leverage the power and the insights from the community, really align all the health practitioners, because again, we cannot do this without the support from the medical community, and get us started on this journey across the ocean. And as a conclusion, I'd like to share maybe 3 dimensions of why we think health open data is important. The first one is for democracy and to answer this expectation of transparency that is expected of us, and that the government has been petitioned about. We also want to improve choice, and NHS Choices is, of course, a very interesting example, but civil society and open innovation can also help us go forward. And the last point is beyond healthcare, beyond the traditional means of delivery, there really is a brave new world that we can. Okay, I'm nearing the end of the speak, so I'll just end here. But beyond what we've known and come to describe as or understand as healthcare, there really is an entire field that we could open to better serve citizens and the public. France has had the luck to combine a very, sometimes too quantitative or quantitatively focused education, but very strong big data and analytics and mathematics education, as well as what we're known for, which is design, right? And so when you think of the Internet of Things, when you think of healthcare devices and those new means of service delivery, I think we're getting there, and we're hopefully will be able to contribute to building those boats to get across the ocean. So thank you very much.
Thank you.
And I'll be happy to answer questions today. Thank you.
Thank you. Now we have Lauren Treisman, who's an executive of the Indigo Trust, which is a UK-based grant-making foundation that funds projects to bring about social change largely in Africa.
Thank you. So you've had an introduction. I was going to give you an overview of what we do, but that's exactly it. And we have a real special interest in innovation, and particularly the role of citizens in this process. How can we empower citizens to demand improved service delivery in their communities? So one of the ways we're doing this is we're supporting centres called Technology Innovation Hubs right across Africa. And essentially what these are spaces where technologists and to some extent social activists can gather together and collaborate and access events and mentorship and training. And we believe that this has a catalytic effect on the number and quality of projects that are being developed in country. And we think this is really important because fundamentally we really believe that the best solutions to Africa's challenges will be devised in Africa itself. So one example of this is there's a new movement of something called citizen reporting platforms. You actually heard a bit of examples in the main plenary this morning. So an example of this is an organisation called WOOGNet in Uganda. And as many of you probably know, there was 2 decades of fighting in the north of Uganda that's resulted in 2 million people being replaced. And the government has now put a peace and reconciliation plan in place which aims to improve the health service delivery in that area. So what this organisation has done is basically set up these voluntary sector accountability committees, and this combines local activists and citizens. And what this enables them to do is from SMS, from simple feature phones, they can basically report challenges in the service delivery, and they land on a map like the one that you can see there. So some real examples of how this has been used in the community. For example, WoogNet managed to receive a message from a lady who'd been turned away from a hospital by a midwife who said that she wasn't in labour when in fact she was. And so she'd got halfway home and couldn't get back to the hospital, was in absolute agony. And what WoogNet was able to do was get an emergency service ambulance to the community straight away. So really exciting results there. And they're working really closely with an organisation called CIPESA. And what they've basically done is train citizen journalists and professional journalists and activists to basically use technology to report what's really taking place on the ground. So first of all, they've collected baseline data, which basically shows what the current status is. And they look at the government's plans and what they've committed in terms of what should be delivered in the area. And then they collect real testimonies, photographs, interviews, etc. on the ground, populate them onto a website to show whether the government promises are actually being delivered. And there's another organisation called Ghana Anti-Corruption Coalition, and this is basically doing similar things in Ghana. It's enabling citizens to report from basic SMS challenges in service delivery. And what they do is basically collate all the information coming in from citizens and use this to advocate for change in policies in the health service. Now, one thing that's really important for all of this is that we essentially need an active citizenry. We need people to be able to actively participate in democracy. Some of you might have come across an organisation before called My Society, and basically they've developed some of the leading democracy websites in the UK. One of them's called They Work For You, and basically what this enables people to do is access information on parliamentary proceedings, also elected representatives. You can see things like MPs' voting patterns, how much they've contributed in Parliament. And what we think is really exciting is that they're starting to partner with organisations right across Africa to develop similar sites. So as you can see here, there's one called Adekro in Ghana, another one called Mzalendo in Kenya, and we're hoping soon that there'll be one in South Africa. And what's really exciting is that even, for example, in the Mzalendo in Kenya, the MPs have actually been phoning up My Society and saying, how can we improve our ratings? So we know that they are actually taking notice. Another example here in Nigeria, this is one of the fantastic projects coming out of one of the hubs I was talking about, a co-creation hub in Nigeria. And basically what they do is create infographics. Many of you probably know that a lot of this data that is being released, it's quite hard to interpret, and a lot of citizens aren't able to interpret it in a way that's meaningful. So what they do is create simple infographics like the ones you can see here that are dividing the government budget into state and sector and various other categories. And it basically enables the public to have more informed debate around these issues. So you can probably see from this infographic here, if it's the little maroon slab over there that is the government expenditure on health, which, as you can see, is a fairly small proportion of the budget. So debate's been sparked around these sorts of issues. This is another really good example that I've seen in Nigeria called Follow the Money. And basically what they did in northern Nigeria, in a community called Bagega, what happened was that there was lead poisoning due to bad mining practices, and the government had promised to release $5.3 million to the communities in order to ensure that there could be correct health service remediation. And what happened was that it didn't actually reach the community. So what they did, they created an infographic which basically showed what the government had promised to the community. And then they went onto the ground and collected real testimonies and stories and photographs and basically showed that actually the health care wasn't being received in the area. And they basically created a really targeted Twitter storm. And this enabled, within 48 hours, the money to in fact be released to the community. And you can see that they've actually been tracking the healthcare treatment in country. Now, I just wanted to sort of point out, some people might not call this strictly transparency, but that a lot of information, everyone has said, sort of across Africa, mobile phones are becoming more and more ubiquitous, but not everyone can get online. And so sometimes it's about ensuring that access to information is available to people on the ground. So I just wanted to give you some examples of some of the sort of projects that are doing this. For example, a Facebook page in Senegal, which enables young people to access information on sexual health. And there's also a project, Kopana, by SHM Foundation in South Africa, that's basically enabling women who've been diagnosed with HIV during pregnancy to have support groups via SMS. And in Ghana, there's an organisation called Motec that is providing voice messages in local languages to mothers of one-year-olds and also pregnant women, so they can basically receive critical health care information on the ground. Thank you very much for listening. There's our Twitter account if anyone wants to tweet about this, and I'm happy to answer questions. Thanks.
That was fantastic. I should just say that the example of the Ushahidi-like platform that you mentioned at the beginning is really fundamental to the way we're trying to approach things here. So we've just started a collaboration with My Society to try and do exactly that, enable people to complain in real time about services and have maps on hotspots on maps and so on. So that's fantastic. Brilliant. Now on to Stefan from GovLab, which is, again, I guess everybody will know about it, a fantastic New York-based resource for the rest of us to learn more about how we can develop our thinking on open data.
Thank you, and I think by now everyone has probably a data indigestion after the after the whirlwind of presentation. So I will try to be somewhat brief and summarize some of the lessons also that we've heard. But so I'm now at GovLab, but I was before I joined GovLab, I was chief of research at the Markle Foundation, which has a long-standing interest in healthcare, and so I oversaw many of the healthcare initiatives which were all about ensuring data liquidity in the system within the US and elsewhere. And I still remember having a meeting with physicians about 10 years ago when we started around something which was shockingly innovative at that time, which was called a personal health record. And no one had heard of that, and everyone was shocked that the data would be released to the patient. And so we had this meeting with those physicians and saying, what do you mean we're going to give data to patients? And so our question was, so where does the data come from? And then suddenly, at that time, I should have had a camera to take a picture of their faces, where suddenly a light bulb went off, is that actually without the patients, we would have no data at all. And so, and I think that's the challenge here, is that how do you actually enable the data that comes from patients to flow back to the patients in order to help them improve their healthcare. But I was asked to reflect, I guess, on the US, which I, of course, won't do in 5 minutes, but it seems to me that while we talk a lot about evidence-based medicine, I think we also will have to move towards evidence-based open data policymaking. And I think we need to have far more evidence about how the open data actually makes, especially in the healthcare environment, makes an impact. And it seems to be that there are 6 buckets that we will have to start populating with evidence, with examples. And here, this morning, we already saw several examples. But the first bucket that we really have to start providing evidence for is, to what extent does open data really provide for accountability and transparency? You have many examples. I mean, in the US, you had CMS recently releasing data about bill charges around outpatient hospital procedures that showed huge disparities, right? And the question is then, what has that then led to, right? I mean, to what extent has it actually really made a change? So the first bucket is really about documenting the impact on accountability. The second bucket is really about what we already discussed as well. To what extent has open data provided more cost-effective interventions? And again, there's a lot of interesting, which also, again, was this morning illustrated, a lot of interesting work around so-called healthcare spotting. I mean, where does the real cost come from, right? I mean, it turns out in the US that 5% of the patients are actually responsible for 60% of the healthcare costs. Well, if you know that, then of course you change your healthcare delivery to a certain extent, and open data then ultimately, which was of course contributing to that insight, ultimately then can show an impact. The third element really is of course about outcomes. I mean, I always said that's really what we should really care about, right? I mean, to a certain extent, you want to make people healthier. And sometimes we forget that by focusing on the healthcare system as opposed to the healthcare of actually patients. And so we need to have more evidence to what extent open data really makes an impact on people's lives. And here, I think it's important to start prioritizing, because you cannot prioritizing what kind of outcomes do you really care about as a country or as a county. Meaning, is it about decrease in heart diseases, is it about obesity, and so on. And I think having those kind of priorities and then really cancer, linking that with the use of open data is going to be important. The fourth bucket of evidence is really about choice. I mean, to what extent has it, and of course you have the evidence probably, but to what extent has it improved the choice of the individual, and as a result of the information available, but also quite often as a result of new reputation management systems that allow the individual to make better choices, both with regard to the providers, but also with regard to the solutions or the treatments that we go for. The fifth is about economic growth, meaning, of course, we are in an economic recession, and I think it's going to be important to show that open data also contributes to new healthcare jobs. Healthcare, of course, is still one of the largest, especially in the US, one of the largest job creators. It is the largest job creator right now. But that's going to eventually, especially if you start dealing with the healthcare cost, it might actually decrease, and you need to have a new wave of actually healthcare jobs. And there are all kinds of exciting new data-driven jobs that don't require a MD to actually be present. And I think this whole notion and a better understanding of what are going to be the healthcare jobs of the future that are data-driven is going to be important. And then the last one is really about innovation, which was mentioned as well. I think what the real power is of open data is to change the healthcare system radically, to move towards a more collaborative kind of healthcare provision, towards where the patient really is empowered and can make decisions, where you have an integrated healthcare delivery system as opposed to a standalone, where self-care and care at the home can be really enabled as opposed to relying on hospitals to take the largest burden. And I think having a better understanding on how open data really can transform the healthcare system is going to be important if we move forward with this open data movement, which has a lot of potential, but unfortunately still lacks too often the evidence to make the case to go to the next step. So thank you.
Thank you. Okay, we'll rushing along. We've got now sort of 15 minutes before we finish, and I'm going to hand over to Ben Goldacre now. So Ben is going to give us just 5 minutes of his thoughts, and then we're going to have a panel made up of a number of our speakers just to sort of wrap up the event. Ben. Sorry, I should say, sort of, I presume that people will know Ben Goldacre. He's probably one of the most, I was going to say notorious, but one of the most brilliant advocates for open data we've got, particularly in the space of science, research and medicine. Thank you.
Thanks. I'm going to say something which might sound really partisan as an epidemiologist, somebody who works on medical data, but before we get to that, I think, everything that we've heard today has been really important stuff, and I think it's really fascinating that the barriers to the valuable work that can be done from greater data sharing aren't technological, they're cultural, and those barriers are being broken down by the people in this room. So it's clear that we need sensible systems for capturing data, for sharing data, and for using data. And today, people have mostly been talking about sharing data, and that's understandable because that's the focus of the wider context of these 2 days. And that kind of straight transparency on government spend and performance is obviously very important. But every time I see a slide that tells me that one area has 2.5 times more X than another area, I want to see something called a funnel plot. I want to know that I'm not just seeing arbitrary random variation in the data. And there is a huge history of elaborate statistical analyses on health data. It's the science of epidemiology. It's kind of what I do for a living. And it disturbs me that the strategy for building UK data capability doesn't mention epidemiology or medical statistics at all. It talks about the importance of social science research, but there's no mention of this medical data, and that's where I think lots of the really great opportunities are. And I think we need to draw on that existing knowledge and those tools to avoid misleading analyses and spurious findings, but also to generate interesting ideas for richer analyses that go beyond the kind of straight data dumps that get talked about a lot of the time. And to be absolutely clear, this isn't protectionism. I want to give this domain knowledge away. I want to get access to the basic tools for analysing medical data out to the wider community. And also, of course, I want to drag existing medical researchers and medical statisticians and epidemiologists into the open data community. And I think that kind of capacity building is really important because it's part of getting more eyes on the data, and that's what will generate more valuable and interesting new use cases. The really interesting uses of the data that gets released are the ones which none of us could have foreseen. It's about getting as many different people thinking about it as possible, and good use cases increase the demand for data, and that draws out better data releases, and it makes the case for openness with examples of real-world benefits. It's striking, lastly, nobody's really talked about individual patient data. And I think that's really where the real action and opportunities are. In particular, that's where, if we can find ways of sharing it safely, we can derive, for example, performance indicators that derive from the very rich, raw individual data that is held by health services locally and nationally. And that's particularly valuable because there's a real problem with big performance indicators that are already being collected by government, and that is they tend to get gamed. Right? I've worked in A&E departments where the 4-hour target means we had a room with a curtain across that wasn't officially in the A&E department. We just put people in there, and then they weren't part of our 4-hour targets anymore. And if we derive performance indicators from very rich data, from core individual patient data, then it's much more difficult for people to game those targets. And if you have a multiplicity of different performance indicators being derived by a large number of different players, then it becomes entirely impossible to game those performance indicators. But also crucially with individual patient data, I think it's really important that we start thinking around how to build capacity on better and more exciting uses of that, because what's going to draw people in to say, yes, it's okay to use my data, isn't going to be, oh, let me see my medical records. I'm not sure that that's really going to be very exciting to people. What's going to draw people in are added value products, things that show people the benefits to them of sharing their data with a wider research community or with an algorithm that can generate interesting knowledge and insights about their own data to them. And that sort of thing will only come from capacity building. So I'm going to speak for less than 5 minutes because I think it's more interesting to hear your questions of the panel. So shall we get everybody who's supposed to be on the panel on the panel? And there are already people putting their hands up, so hurry, hurry. I think it's all of you, isn't it? No Tim? Okay. So there's serious eminence inequality between chair and panel here, but I'm going to keep you to time. So let's be brief. And you had your hand up from the very moment. Can you say who you are, just very briefly, before your question?
My name is Ana Saric. I come from Montenegro, from Center for Monitoring and Research. We just did corruption risk assessment in the healthcare system of Montenegro, so that's why I'm interested. Today, we have heard a lot of useful information, mainly concentrated on transparency in the patient care and quality of the patient care obtained. The thing that we slightly disregarded, which was partially addressed by Mr. Poulter, I think, was public funds, which are directly influencing quality of patient services and directly influencing effectiveness of these services. Researches of WHO have shown that 18 billion of euros are being lost due to corruption of public funds on the level of the EU. And me coming from a country that spends 170 million euros annually on healthcare, which means 250 euros per capita, I'm very interested that those public funds are not lost due to corruption. So I have a few questions. Which I would like to address to all panelists, which could give me...
Swiftly, if you can.
Swiftly, they are like in 1 minute. How do governments react on open data, on results of the open data? Do they control them? Does the open data have effects on the government's work? Do you research and publish open data on all aspects of public procurement, including funds spent, control of conflicts of interest, and contracts implementation? And third question, do you research on relation of pharmaceutical companies with healthcare sectors? How are the medicines being registered? Procedures of placement on essential list of medicines, which means medicines that are paid by the government, and prescription of medicines.
So, forgive me, it sounds like these are actually quite specific questions for specific governments, but perhaps Stefan and Lauren, since you work on transparency, in particular in developing countries, I wonder if you had any comments on the impact that open data can have on corruption.
Sure. Well, I mean, I'll try and keep this fairly broad because obviously for every different African country there'll be very, very different answers to this. But I think one of the critical things which I'm always banging on about is it's what citizens are willing to do to hold governments to account that will lead to accountability mechanisms in the data. So releasing data in itself is unlikely to lead to greater accountability. But if you can present this in a way that's meaningful to the general public and you have an empowered civil society, then it does often lead to real results. And I think a couple of the examples I gave there, so for example the Follow the Money campaign, I don't see any reason why that's not happening more in the UK, for example, or other countries, because that was basically two young guys that don't even have a proper organisation established yet, and they've managed to campaign for the release of $5.3 million of funds. So I think actually quite grassroots targeted campaigns can actually lead to accountability mechanisms.
Do we have more questions? And should we perhaps take two if you're queuing up?
Hello, it's Roger Taylor from Dr. Foster. I had a question really for Mike Hobday, principally, but I think actually, Ben, it applies to you as well. As like your comment about trying to drag epidemiologists into the open data world. And on this point about capacity building, I think one of the issues that a lot of the organisations that you would really hope would step forward into this space in the third sector or in the media have been a little slow and a little uncertain as to how to approach it. And I wondered, Mike, why you felt... I mean, I think that what you've done is absolutely brilliant and exactly what organisations like yours should be doing, but you remain a bit exceptional, and why do you think that is? And similarly, Ben, why do you think epidemiologists don't just run at open data in the way that you might expect them to?
I think the need for evidence within the NHS, and particularly the need for evidence on financial issues, is relatively new. The NHS in the UK has been in this luxurious position for a number of years where it didn't have to worry about money. And I think, to me, it's suddenly become very obvious that evidence is needed. It's almost become an opportunity to bring evidence back into policy making in a way that it hadn't needed to be there. Why hasn't it happened more? I think that there's a slightly wider issue, that all the things we talk about, I think we sometimes think ourselves that they're a little bit nerdy. But actually, they're really exciting, and we've got to tell that more exciting story about it, and we have to inspire people with what data and analysis, and in health, the combination of that with clinical input can really drive. And if we talk about it more, we can get more people on board.
I shouldn't answer your question really because I'm the chair, but I can tell you very briefly. I mean, academics follow money, and everything that I've done in this area has really been in my kind of hobby time. So I had the idea for the statins prescribing map. It was implemented with the help of some nerds, some of whom are in this room, and we've tried to push that forwards, and it's really interesting that you can get sort of blue tack and string money for that kind of thing, 5 or 10 grand. I can get 300 grand to do a very boring bit of observational epidemiology on electronic health records that is exactly the same as what everybody else does. So I think we need to get funding for good quality open data projects to academics to make sure that it's not a blue tack and string project, it's real serious business. Because actually I think the stuff that me and Carl do in our hobby time is much more valuable than what we really do in our day jobs, to be honest. But at the same time, we've got to be very careful because when you start, academics are clever people, right? And if you say, oh, big data and open data are the words you have to put in their grant proposals, then they'll just do it and they'll get the money to carry on doing exactly what they were doing before. 7 years ago, I put the word translational arbitrarily in one grant application and got the money, and it had nothing to do with translational research whatsoever. It's just what we do. There was another word. Can we try and fit two more in? Is that cheeky? So one here.
You said, Ben, the real rich source of data. Sorry, I'm Bill Roberts from a company called Swirl. The real rich source of data in healthcare is in the personal stuff, and health will be, I think, the pilot case of balancing the needs of protecting the interests of the individual with the potential benefits of analysing information about them. In 1 minute, how are we going to solve this very difficult problem?
I'd love to hear a 25-second précis on that. And, sorry, one more.
Damaris Fritskiewicz from South Africa. I'm a health activist, and I don't hear the community voice in anything of that you said. It's about the community, but not with the community. So my question would be, if you collect this data and you make the data available, what is your community arm in what you're doing?
So 2 questions which I very unwisely took, and they both have answers that are about 5 hours long. Whoever dives in first on either, how do we work safely with IPD or community engagement?
Community engagement, I would just say that you're exactly right. In those areas where we have had existing community structures that we can appeal to, so some of the areas of civic society are working, actually surprisingly, in the police data that's been released in the UK, went very directly into local activist groups who would also kind of communicate with their local policing communities. You do need that, and you've got to have that conversation there. You're absolutely right. I think we probably do need to engineer that much more explicitly into our programs. It relates to the citizen-sourced aspect here too.
Yeah, exactly. And I mean, just in 20 seconds, basically you have to build civil society, a strong civil society, beyond the data in a way that you'd normally build civil society in order to respond to this.
Maybe on privacy, because it's a question that's been specifically challenging in France. There's a quote by a French poet, Antoine de Saint-Exupéry, who says, if you're trying to build a boat, don't drum up people to cut wood, teach them to long for the endless immensity of the sea, right? So what we need is vision. And I completely agree with my fellow panelists on the need for evidence, and that's really what we've been trying to build with this all-encompassing debate, because as different stakeholders from very different walks of life and sectors come to the table, they can bring evidence on why access to information and to specific data that may be personal in nature or anonymous but more precise could be important. And so that helps us strike a better balance between the need to protect patient information and individual information and open data and be transparent.
Can I say one more thing on the community? I totally agree with that, but I think one of the exciting things that can happen and will happen is to move from quantified self to quantified community. And I think not enough attention is paid on actually communities as data producers, and then ultimately actually also becoming an active player in this open data environment.
Well, this session is timed to last 98 minutes, and we've hit 99. Thank you very much to everybody on the panel, the hosts, and the people who spoke earlier. Thank you.